Right now, over 90% of adults are harboring a dormant, incurable virus deep within their nervous system. This pathogen is the Varicella-Zoster virus, an organism most of us know simply as childhood chickenpox. During a primary infection, the virus spreads through the air with remarkable efficiency. Once inhaled, it replicates rapidly, eventually erupting across the skin as a highly contagious, intensely itchy, starry sky rash. For most children, the immune system eventually gains the upper hand. The fever breaks, and within a week, the superficial blisters dry out and scab over, giving the appearance that the disease has been defeated. However, the disappearing rash only signals the end of the first phase. The virus has successfully moved from an active infection into a lifelong, quiet invasion. Facing an active immune response, the surviving viral particles abandon the surface of the skin and retreat deep into the host's body. They hijack the body's own wiring. The particles travel backward up the sensory nerve pathways, moving away from the extremities and heading directly toward the spine. Here, the virus enters a state of latency. It parks itself inside the dorsal root ganglia, clusters of nerve tissue situated just outside the spinal cord. By shutting down its own replication and going completely dormant, it effectively hides from passing immune cells. It is a patient houses for 5, 10, or even 50 years without causing a single symptom. The noisy skin infection has successfully transitioned into a silent, undetectable neurological resident, simply waiting for the host's cellular defenses to drop. As we age past 50, or when we experience extreme stress or immune suppression, our cellular guards inevitably weaken. The T cells tasked with keeping the virus in check lose their effectiveness. This medical diagram illustrates the failure point. When immune control is lost, the virus reactivates inside the spinal ganglion, breaching containment. In a reverse commute, the multiplied virus travels back down the exact same nerve pathway, heading straight for the skin. This clinical photograph captures the signature of that reactivation. The blisters are strictly confined to a single band on one side of the body. This happens because the virus travels along one specific nerve root, known as a dermatome. While you cannot catch shingles from an active patient, the virus inside those blisters remains completely viable. Direct contact with the fluid transmits the pathogen to an unvaccinated person, triggering a primary case of chickenpox. The pathogen weaponizes the human aging process, using our own nervous system as the highway to launch a devastating secondary attack. Biologically, shingles operates as an active inflammatory assault on the nerve fiber. The blisters are simply the outward symptom of that internal damage. The ordeal begins with a prodromal phase. Days before any rash appears, the migrating virus causes intense localized pain. Because the skin looks completely normal at this stage, the pain is frequently misdiagnosed as a muscle tear or an internal organ issue. The structural risks vary depending on which nerve the virus occupies. If it travels along the ophthalmic branch of the trigeminal nerve, the infection spreads to the eye, creating an immediate risk of permanent blindness. The most debilitating complication is post-herpetic neuralgia, or PHN. The virus inflicts severe physical damage and scarring along the nerve. This scarred architecture misfires, causing agonizing burning pain that persists for months or years after the blisters clear. The skin eventually clears, but the structural scars on the nerves often remain, leaving patients with a permanent, invisible neurological injury. The medical community has developed a population-level defense system designed to intercept the virus at both stages of its life cycle. Our first defense, the childhood varicella vaccine, blocks initial infection, resulting in 92% fewer cases. For adults already carrying the dormant virus, the second line of defense is the Shingles vaccine, boosting immunity to suppress reactivation with over 90%. Systemic antivirals like valacyclovir are highly effective at stopping viral replication and preventing permanent nerve damage, but only if they are administered within 3 days of the rash appearing. Shingles is a severe medical emergency. The information presented here is for educational purposes, and immediate professional clinical orientation is essential. You can take proactive control of your neurological health by speaking with your healthcare provider today about your eligibility for the adult Shingles vaccine. We are no longer helpless hosts. Through clinical awareness and preventative medicine, we finally have the tools to break the cycle of the Varicella-Zoster virus.